All right, well, good morning, everyone, and welcome. Thank you so much for joining us for today's webinar on expanding access to overdose prevention supplies in Pennsylvania through a brand new initiative, the Pennsylvania Overdose Prevention Program. My name is Sam Cook, and I serve as the Director of Policy and Planning at the Pennsylvania Commission on Crime and Delinquency, or PCCD, as we're more commonly known. And I'm joined by a few of my colleagues from the agency, along with our friends at the Pennsylvania Department of Drug and Alcohol Programs, who are our partners in this new program. So before we begin, just a couple of housekeeping notes to share. This webinar is being recorded and it'll be posted on our website as soon as it becomes available. We do encourage you to check your audio settings just to make sure you're able to hear us clearly during today's presentation using your computer or other device. Please note that we can't hear you. However, you will be able to submit written questions through the Q&A feature in the live event, and we certainly encourage you to do that throughout today's presentation. The questions that are submitted through the feature, just know that it won't be visible instantly to the whole group, but it will be received and reviewed by our staff. And our team has allotted some time at the end of the webinar to answer those questions that have been submitted by participants throughout the session. So to the extent possible, we'll try to get through as many of those as we can. But if we aren't able to get through them all, we'll certainly do our best to answer those questions offline through another means of communication. In addition to the webinar recording, we'll also be posting a copy of slides from today's session, so don't feel like you have to scribble everything down. And with that said, we'll just do a quick preview of what's on our agenda for today's session. So that'll include an overview of Pennsylvania overdose trends from Jordan Lewis at DDAP. We'll then talk a little bit about the efforts that we've made to date on expanding access to overdose prevention supplies, including Naloxone, and how we're transitioning the Naloxone for First Responders program into the Pennsylvania Overdose Prevention Program. We'll then have some special guests providing us with their insights and perspectives on two important topics. One is around drug checking strips, so fentanyl test strips and xylazine test strips specifically, as well as some insights around Naloxone and the different formulations that are currently available that we're able to purchase through the program, and just some context and research around some of those different formulations. And then, as I mentioned before, we'll hold some time at the end for any questions that have been submitted and just dive through it with the group. So with all that being said, I'd like to now turn things over to my colleague, Jordan Lewis, who's going to be providing a bit of an overview on overdose trends in the Commonwealth. So Jordan, you want to take it away?
Thanks, Sam. Good morning, everyone. For those who don't know me, my name is Jordan Lewis, and I'm the Policy Director at the Pennsylvania Department of Drug and Alcohol Programs. I really appreciate everyone taking time out of their day to join us this morning. Before we dive into discussing the new program, I want to first give a brief overview of how the overdose epidemic has evolved in Pennsylvania over the past several years, particularly during the course of time since launching the Naloxone for First Responders program back in 2017. The graph on the left here is familiar to many of you. It represents the number of overdose deaths per year over the past decade in Pennsylvania. These data come from the Department of Health's Office of Drug Surveillance and Misuse Prevention and represent death data collected as of July 2023. Please do note that 2021 and 22 data are still considered preliminary as final reports trickle in. As you can see, 2017 was the peak year of overdose deaths in Pennsylvania, with opioids contributing to 86% of those deaths. We were encouraged to see an 18% decrease in deaths in 2018 that persisted into 2019, but unfortunately and unsurprisingly, this number began to rise again during the pandemic years. Beyond the obvious issues that came with the pandemic, also came a change in the drug supply. So a key difference that we're seeing today versus back in 2017 is the number of deaths where fentanyl was involved. In 2017, fentanyl contributed to about 66% of overdose deaths, while last year that number climbed to 78%. We're also seeing a significant increase in deaths today where fentanyl is combined with non-opioid drugs like cocaine, methamphetamine, and benzodiazepines, which really underscores the need for education and resources around tactics like carrying naloxone and using fentanyl test strips. even when you wouldn't expect an opioid to be present in your drugs. The graph on the right also comes from the Department of Health and illustrates the growing disparity in overdose deaths when comparing Black and white Pennsylvanians. Last year, Black Pennsylvanians died of overdoses at a rate that was 2.3 times higher than white Pennsylvanians, even though overall white Pennsylvanians are dying in higher numbers simply due to the demographic makeup of the state. This is obviously a very concerning trend that we continue to monitor both in Pennsylvania and nationally, and was a major driver in why we're using $6 million in opioid settlement funds that were appropriated to our department to provide grants to BIPOC-led and BIPOC-serving organizations across the Commonwealth. These data also underscore the continued and dire need for targeted harm reduction outreach to underserved communities of color in Pennsylvania. In addition to the increasing prevalence of fentanyl in drugs, xylazine has also been an emerging trend in Pennsylvania for the past several years. According to data from the Department of Health, in 2021, 39 counties reported overdose deaths where xylazine was present in the decedent's toxicology report, up from 3 counties in 2018 and representing over 10 times as many deaths compared to 2018. Xylazine is not an opioid. It's a veterinary sedative used to tranquilize animals during procedures, but it has been added to many opioid street drugs in order to prolong their effects. Although xylazine is not responsive to naloxone, it is still recommended that people use naloxone to attempt to reverse an overdose, as the naloxone will work on the opioid. However, other tactics like oxygen or rescue breathing may also be necessary. Within the past several months, xylazine test strips have also been added to the market so that drug users may test their drugs for the presence of xylazine. And lastly, I just want to highlight the Office of Drug Surveillance and Misuse Prevention's interactive data report as an incredible resource, an incredible wealth of data, and it's where we pulled the data that I just presented here this morning. This dashboard is regularly updated with detailed overdose drug specificity and demographic data going back to 2017, and in some cases as far back as 2012.
Sorry about that. All right. So with all of that context in mind, we wanted to take a little bit of a sort of history reflection, if you will, on some of the ways that Pennsylvania has worked to expand access to naloxone, which, as Jordan noted, is such a critical strategy. We know people can't recover if they aren't alive. People can't they deserve second, third, and fourth, and many more chances. So the Naloxone for First Responders program launched in 2017 at the Pennsylvania Commission on Crime and Delinquency in partnership with DDAP, as well as the Department of Health and some other members of the Interagency Opioid Command Center. And so we wanted to provide just a little bit of a highlight on some of the kind of history of that program, the way it's evolved, and some of its impact. So as I mentioned, the program was launched in November of 2017, and it was originally really intended to expand access to Narcan, which is intranasal 4 milligram, to more traditional first responder groups like law enforcement, EMS, et cetera, really with the intent of ensuring that those traditional first responders were equipped with the life-saving tool as part of their toolkit, so to speak. We obviously know that first responders often are not those traditional groups, right? Their friends, their families, their other drug users. And so the program definitely evolved over 5 years to kind of account for that. So way back in 2017, we were tasked with starting that program with about $5 million in state general government operating funds to use over a 2-year period. As I mentioned, it was an initiative that was supported by the then Pennsylvania Opioid Command Center, among many other really important initiatives like naloxone giveaway days, the standing order signed by Physician General Rachel Levine at the time. And so all of these things were really designed to increase access, awareness, and carrying and utilization of naloxone. So the program was designed to incorporate a network of centralized coordinating entities. There was at least one covering every single county in the Commonwealth. Many of them were single county authorities, some were EMS agencies, some were DA's offices, other things, but this group of 48 entities really served as kind of the local supply for a lot of different first responders. I want to note, and I always like to give DDAP a shout out, we started with a fairly small investment of state dollars, and DDAP's investment of federal state opioid response dollars really beginning in 2019, 2020 was a real game changer for this program. And the timing of that investment really just was incredibly important, especially as we headed into the COVID-19 pandemic. So we know that obviously in March of 2020, we were able to work with DDAP and others to organize an emergency supply to send out statewide kind of early in those lockdown days. And as we kind of headed further in, I mentioned some of the programmatic adjustments. We really started to recognize that while there's a role for law enforcement and more traditional first responders, we really wanted to emphasize groups like harm reduction organizations, syringe service programs, and other grassroots community organizations who we knew were really serving on the front lines and working closely with people who use drugs, people who might be in recovery, people who are likely to need and use naloxone. And so the program grew further. We were able to work with our partners at Prevention Point Pittsburgh and Next District to support a statewide mail-to-home program that they stood up, which has been really incredible. It's sent doses to every single county in the entire Commonwealth. And I think, the transition over to an emphasis on harm reduction being a priority group for CCEs to give kits to, as well as for our statewide distribution efforts, really amplified the program's reach, and just wanted to take a moment to provide some well-deserved kudos to all of the organizations, whether traditional first responders or harm reduction groups, whoever you are. I mean, this is really a program that has relied on folks on the ground receiving supplies and then doing their part in their communities. So just wanted to shout out to all the folks that have made that program really a success and possible over the last 5 years. So when we say first responders, obviously in some circles, traditional first responders like fire, EMS, law enforcement come to mind, but we really tried to take a broad approach to who we consider to be a first responder who can get naloxone through this program over the years. I mentioned, community groups being a real emphasis. We've also supplied to healthcare and hospitals, primary care settings, emergency rooms. We've also tried to emphasize reach in the justice and particularly reentry space, knowing how vulnerable folks who are recently incarcerated can be to fatal overdose. And, we've certainly had partnerships with mental and behavioral health providers, shelters, social services, other treatment providers, and some other groups, right? Education. We've seen college campuses and K-12 schools really interested in having that product available, as well as groups like Parks and Recreation, restaurants and hospitality, businesses and transportation. So there's been a real significant coverage through the program over the years, through that definition of first responders. So 5 years later, what has that effort looked like? Well, one way to capture it is kind of the volume of supply that we've been able to provide, again, thanks to the generosity of DDAP and the efforts of all of our state and local partners. So over the past 5 years, we have purchased and distributed more than 1.3 million doses of naloxone since the launch. And so we think, if you're looking at that bar or the line graph rather, the CCE distribution is captured in that dark blue, and non-CCE through our statewide portal, which launched in March of 2021, is in that shaded yellow. And so we've really seen that portal take off. We know that for a lot of groups, it's been able to support some pretty innovative naloxone distribution strategies. And so we're just really proud of all the effort that goes behind that kind of big number that you see there. Because it's a PCCD presentation, it wouldn't be one without a map. We really like presenting data through maps, and I think this one tells a really important story, right? It's basically all of those kits in that bar chart before, that graphic that I just showed, but this is capturing that volume and that distribution at a zip code level. So You can see that this is, we really have achieved what I would consider to be statewide reach. There's certainly some areas that aren't shaded. I think one of my colleagues joked that for the most part, those are some pretty low populated areas. But I think, this is definitely not the full picture. We certainly know that some of the kits that we've distributed have gone further out into different places, but these are all of the zip codes that we've either shipped kits to or that CCEs have reported distributing kits to over the past 5 years. So what does all that mean in terms of impact? So, obviously getting naloxone out is important. We know that there's a lot of research around saturation being an incredibly important overdose prevention and reduction strategy. And we've been able to track sort of the number of overdose reversals reported using PCCD purchased medication over 5 years. And what we've heard back is that there's been at least 24,000 overdose reversals that have been made using products supported through the Naloxone for First Responders program. We know that it is definitely an undercount, so we expect that it was probably used in a lot more situations than that, but we appreciate the efforts that folks made to kind of track and share that data, because I think it does really emphasize the impact and the scale of this program's reach over the years. So back to our timeline, this is sort of, if there was a "you are here" sort of dot somewhere, imagine that showing up on this map. So in fall of last year, Pennsylvania took a huge step in enacting law that would decriminalize drug checking strips. So that's Act 111 of 2022. I know that our friends Julia and Carla will be talking a little bit more about how much of a big deal that legislation was. So, with that kind of new policy development where we had xylazine test strips and fentanyl test strips now being decriminalized under Pennsylvania law, certainly naloxone distribution, there's new formulations coming on the market, over-the-counter developments. And so we really felt like it was a good time to kind of reimagine and revamp the Naloxone for First Responders program a little bit. And so you can see the very last stop on that timeline is August of 2023, today, in fact, where we're launching the next chapter of the Naloxone for First Responders program, which is the Pennsylvania Overdose Prevention Program. If you're a fan of acronyms, the new one is POP. Yeah, we're just really excited about this kind of next chapter kicking off. So without further ado, what will the Pennsylvania Overdose Prevention Program look like? So we'll try to build on the progress that we've made through the Naloxone for First Responders program, really by making additional harm reduction supplies available to people and communities across the Commonwealth. So in terms of kind of high-level characterizations of the program, we're really imagining this to be a one-stop shop where both individuals and organizations who are seeking either naloxone or related harm reduction supplies like fentanyl and xylazine test strips can get those supplies. We also are hoping this program will build into a clearinghouse for information, training, technical assistance, other types of resources to help groups who are involved in this type of work in their communities. And there will continue to be an emphasis, as there was with the Naloxone for First Responders program, on statewide and regional saturation and accessibility. So we really want to make sure, as we did with the previous edition of the program, that we're getting naloxone and harm reduction supplies into the hands of people who use drugs, people who serve them, people who know them, people who love them. Our official program launch date is tomorrow. That's sort of the go live on lots of things. And we wanted to give you guys kind of a preview of what this will look like so you can kind of make plans and figure out if this program might be something that can help your organization do great work in your community. So in terms of what's new, we kind of talked about this already, but the biggest change arguably is that it's not just going to be naloxone anymore. So we're going to provide both naloxone as well as drug checking strips, and those would be both fentanyl test strips and xylazine test strips that we can purchase for organizations. We're also moving and expanding the naloxone formulations that are provided through the program. So historically, it's really focused on intranasal 4 milligram. That now includes additional formulations of intranasal, as well as the option to request intramuscular naloxone as well. In our Naloxone for First Responders program, a lot of what we were doing with our CCEs in particular was building out formulas to figure out how much supply folks needed, factoring in things like population and overdose trends. We're not going to do that so much anymore. We're really kind of trying to shift more towards a demand-based model. So providing organizations with the supply that they think they need based on their historical distribution or upcoming events, the number of folks that they actively serve, those types of things. We are still going to utilize a model that has some recognized local entities that are available for folks who are in the community seeking a more immediate supply or a smaller supply, maybe something that's a little bit lower in volume than what we would provide directly through the program. And I did want to note that all of our CCEs are going to kind of continue to be providing naloxone and serving as that local point of contact through at least the end of this year. So they'll continue to be a resource. If you've used your CCEs before to get naloxone, you can continue to do so moving forward. And then, the other shift is rather than having a single CCE or recognized entity in a given area, we anticipate that by virtue of the fact that there are different products and different services, we're going to be moving towards a model where there's likely going to be multiple recognized entities that are serving a single service area. So that's what will change. What won't change, pretty much more or less, is, again, providing harm reduction supplies and medication at no cost, both to individuals and organizations. So we've already gotten the question, will I need to pay for anything? And the answer to that is no. We cover all of those costs. It'll continue to focus on the highest need populations. And I think worth noting, and again, our friends, down the road will kind of spell this out a little bit further, but this will look different for naloxone compared to drug checking strips. So there's some considerations for organizations, I think, that are important to mull over. And then we will also continue to have program guidelines that establish kind of the expectations and the rules of the road for organizations that get supplies through the program, things like inventory control, making sure that product is stored properly according to manufacturer instructions, a little bit of data and reporting requirements as well. So if you're thinking, all right, gotcha, it's changing, how do I get supplies? So we put this together. It's also available in our program guidelines. So for individuals who are seeking for personal use, we're going to continue to encourage folks to utilize options like the mail to home program. Certainly for naloxone, you can continue to go to pharmacies and use that standing order, or not with some of the over-the-counter products that are coming online. We will also be producing a resource map where you can find recognized entities within your region who can also provide you with naloxone and or test strips in your community. If you're an organization or a group that's seeking a relatively small supply for your own use or distribution, so think treatment centers for patients at discharge, or if you're a community group that has an event coming up, the Overdose Prevention Program, you could certainly request through one of those recognized entities. You could also request directly from PCCD through a new POP request form, which we'll get through in just a little bit. And finally, if you're an organization or a group that's seeking kind of a larger supply for both distributing maybe within your organization, but also within your broader community, for example, a harm reduction organization, we'd certainly encourage you to think about potentially becoming a recognized entity. You can apply to do that using the POP request form. You could also obviously seek a one-off supply through that request form as well. All right, so we mentioned that interactive resource map. It's not quite live yet, but we're planning to launch that likely later this week. However, the goal of this is really going to be to continue to add in those recognized entities. So you'll be able to kind of click through and find, based on where you live or where you're working, an organization that offers naloxone. You'll be able to see the types of formulations that they offer, as well as if they also offer test strips or one or the other. So we're thinking this will kind of be a place to check out who's doing that work in your community, where you can get a local supply. And that'll be where folks who have applied and been approved to be recognized entities will be listed as well. So we're pretty excited for that. We'll keep folks posted on the official launch. We're just putting the finishing touches on that, so to speak. So for requesting supplies through the POP request form, we just wanted to kind of, emphasize there's a lot of different questions around kind of the basic logistics, right? So how much product do you need? What's your organization name, contact information, shipping address, and all that's really important so that we can kind of fulfill the orders that you've requested. We work with vendors who often have a lot of sort of back-end verification, especially around shipping addresses, so they can make sure that the product you've asked for gets to the right place. But really wanted to sort of also note some of the kind of additional information we request through that form. So we're trying to understand kind of how you'll use either the naloxone kits or the test strips that you're requesting. And it's really, really important when you get to that question around the description of need and planned use of requested supplies, that you provide as much information as you can, really to paint the picture of how your organization is planning to use what we'll give you, sort of what your history with doing this is, if possible. Definitely not looking for a thesis by any means, but it should be something that's a little bit more than one sentence, just so that it can minimize some of the back and forth. Because if we don't understand what it is that you're hoping to do with the product, we will be reaching out to probably get additional information from you, just to make sure that that intended use fits with our guidelines. So the more information and the more detailed information you can provide up front, definitely is going to be helpful and streamline things a bit on both ends. We also provide the opportunity for you to indicate if you have a brand preference on any of those offered products. And we also obviously ask you how much product you want, and there are some quantities that we ask you to keep in mind. So just, please, as you're going through that form, pay attention to some of the prompts, just because, again, the more clear information that you provide up front, the less back and forth you'll have to have with our team, and the more quickly we can process your request. I did want to just do a little reminder before we transition to recognized entities, that the supplies that we're providing through this program really are intended for harm reduction purposes only. And I think that's especially true for the drug checking strips. So the drug checking strips that we can purchase at PCCD really are not designed to be used for urine analysis, drug screening, or investigative purposes. So just wanted to say that to folks, if that's something that your organization was thinking that would be provided through this, the products that we purchased really weren't designed or intended for that use. And our program guidelines are really emphasizing that these are for personal use only, for harm reduction use only. So you'll hear that a couple more times, so just wanted to say it at the outset. So I mentioned recognized entities and wanted to just share a little bit more about what that would entail in case it's something that your organization is interested in doing. So in essence, a recognized entity will really serve as a primary local point of contact for supplies in a particular community, county, region. And we'll ask groups who are interested in doing this type of work for us to really develop a distribution and outreach strategy focused on people and organizations with greatest needs. So we are going to prioritize our supply for recognized entities, just noting that they're going to kind of be on the front line for providing product on a daily basis. So that'll include some expectations around quarterly data reporting, certainly keeping us posted on any changes, that kind of thing. So wanted to make it clear too that, recognized entities don't have to distribute all types of naloxone or all types of drug checking supplies. If you're only really interested in doing one type of product, that's certainly fine. We'll be able to kind of work with you to choose what formulations and or brands that you would like to be able to provide in the community. And then through that resource map, folks will be able to see what you offer and decide if they should reach out to you to acquire that supply. So we mentioned some of these responsibilities already. Obviously, if you're going to serve as a local point of contact, we hope that you will be responsive to those requests that come in. So there is a little bit of staff time likely involved in this, or people time, so to speak. And I mentioned the quarterly data reporting. We typically are asking you to kind of track how much you received from us, how much you distributed, and if you do get any data back on utilization, certainly passing that along. So to become a recognized entity, you'll actually submit an application via the POP request form. So there's a prompt in that request form that asks if you're interested in applying. If you select yes, it will take you to that application form. You'll be asked to answer some questions about what your organization does, how your history kind of looks in that particular community or that type of work, and just other kinds of questions around capabilities and connection and all that good stuff. We'll also ask you to provide a little bit of information on sort of your planned distribution strategy, what products you're interested in distributing, and that kind of thing. And then after the application is submitted, we'll take a look at it. We'll be in touch if we have questions. And if you are approved for that status, we will be in touch with you around completing a more formal agreement that just sort of confirms your ability to comply with program requirements. I should say too, from a supply perspective, these recognized entities really are going to be designing strategies around at least a year worth of distribution in terms of the amount of supply that they think that they need and that we can reserve for them, just because we want to make sure that that local supply is as available as possible. We can work with you on kind of delivery timing and all that good stuff to get around storage needs and that kind of thing. So that's sort of the kind of nitty gritty of the program structure. I did want to sort of, highlight for drug checking strips as we transition to the next piece of our presentation. But before I do that, I actually do just want to note for the group, we have a website that's live, so I'll drop the link in the chat. If you are interested in learning more, you can find out everything you need to know about the overdose prevention program using this website. It provides a link to that request form that I noted before. So I'll also put that link in the chat as well. And you can see that we've put the types of products that are available are going to be listed right up front in that request form so that you have an easy way to see what it is that you can request later on into the form. So there's also a link to that mail to home program that we referenced before, and there's also a link to our contact information if you have any questions as you're completing that form. So back to our regularly scheduled program in terms of the drug checking strips, we do have about $2 million available to purchase those strips through the program, and that request form is now live. So if you've already completed a preliminary request form, just sit tight. We're in our process of completing that. If you haven't yet submitted a form to us, please feel free to do so. We are going to try to get through those as quickly as we can. And you'll see it at the bottom below, just that reminder again that this is not for urine testing or screening or anything like that. So I'm going to stop talking, blessedly for all of you, and pass things along to my colleague Julia from Prevention Point Pittsburgh, who's going to talk a little bit about fentanyl and xylazine test strips and just how some of those tools work. So Julia, the floor is yours.
Thanks, Sam. Can you hear me okay?
Yep, loud and clear.
Awesome. All right. So yeah, just talking a little bit about fentanyl and xylazine test strips. Prevention Point has been distributing both for a little while. I put on here as well that I was also the founder and I'm still a volunteer for the Pittsburgh Dance Safe chapter. We're going to be talking a little bit about Dance Safe's fentanyl test strips today, and they're a really great resource for other drug checking materials if any of you would like to chat about that in the future. Next slide, please. Thank you. So this was a little bit more relevant for when we were talking to our current CCEs, which Sam mentioned, folks in our counties that are getting naloxone out to people already who will be able to carry these new products. But I thought it would be relevant to go over here too, because it is kind of like she mentioned, naloxone, we really want, or Narcan, everybody to carry. We want people to be a good Samaritan, to be able to respond in the event of an overdose, and do all of that kind of stuff. But with test strips are just for people who use drugs and those who are close to them. So some recommendations that we had to get those out in that way were EMS leave behinds for past overdose calls, hospitals, treatment providers, but I would like to provide the caveat that if a person is concerned that anything about their treatment will change or there would be any kind of repercussion for admitting that they are using drugs, then that's probably not going to be a great resource for it. The best thing is really you all, people and organizations in your counties who are already reaching people who use drugs, especially those who are currently already reaching them with naloxone and harm reduction information before these test strips were given out. That really gives a chance for organizations to build rapport in the correct way for this. Next slide, please. Okay, myths and uses of drug checking strips. I did just kind of want to go over that fentanyl and xylazine test strips, again, are not for checking urine for the presence of these substances. Not only is this a program that obviously is focused on this grassroots harm reduction purpose to serve people who use drugs, but these strips are not properly formulated to test urine. They were, at least in the case of DanceSafe, manufactured specifically for people who use drugs to perform drug checking with, and the amount of water that would be present in urine would be far too much of a dilution for this to completely make sense. Another common one we get is that Halloween candy does not need to be tested for fentanyl or other drugs. I know that the Next mailing program received this quite a bit last October, and as we're heading into the fall, I would just like to remind everyone who will be distributing test strips that that is still not the case. And finally, that it's not possible to overdose from casual contact with fentanyl. And that's all these kind of media stories that we're seeing about anybody coming into a room that had a person who uses fentanyl or fentanyl in it and just automatically saying that they're overdosing. I know we'll go over a little bit more about naloxone and overdose later in this presentation, but somebody would be unconscious and unresponsive if they're experiencing an opioid overdose, which is important to keep in mind here. Okay, so drug checking tools I did want to mention are truly a band-aid on a bigger issue, although they're very important, and I think it's going to be game-changing for a lot of people who use drugs in Pennsylvania to have access to cost-free fentanyl and xylazine test strips. What would really change things would be a safe supply for people who use drugs. As long as there are these types of adulterants entering the drug supply, which they will continue to under prohibition, we're just going to have to keep coming up with more of these drug checking strips and more drug checking materials and resources in order to try to keep up with the growing supply and things that could be dangerous for people who use drugs. And we also need more syringe service programs throughout Pennsylvania. I know my colleague Carla is about to talk about that quite a lot more with legislative advocacy stuff, but we really do need syringe service programs. They are the most accurate and supportive of people who use drugs. These programs are the most qualified to distribute these drug checking tools. And with only having two main ones in Pennsylvania on opposite sides of the state, it does make it a little harder to understand who is providing this outreach and who's the best places to distribute them to. Okay, so I wanted to put this up before I do the actual demonstration because I know that this is being recorded and slides can be available for people afterwards. So I did want to have this information written down, but I'm also going to go over that live as I do the little demonstration. So whenever folks are ready, I can switch to just camera.
All right, switching you over now.
Thank you.
You're welcome.
All right. Everybody able to see this?
Yep, looks good.
All right. So we have our fentanyl test strip here. The one that I'm going to be using for this demo is DanceSafe brand, and I'm going to mention that because the dilution will be different if you plan to use another brand of test strip. The other ones are usually BT and X. They're seen in a little green package. You would have to do kind of a bunch of different extra steps instead of the same dilution to test stimulants, MDMA, methamphetamine with the BTNX ones. So these ones are white and yellow. On the back, there's a QR code. So if you would forget any of these things that I'm saying now and you don't have another instruction thing somewhere, this will send you right to Dan Steve some instructions for them. Other things you will need is a cooker or a bottle cap if you don't have something exactly like this, your substance, and some water. All right, so are we looking at my desk?
We are. It looks great.
Okay. So guys, this is sugar. This is for demonstration purposes only. You're going to take about an amount of your substance that's about 2 grains of rice size. You're going to estimate that and stick it here in the bottom of your cooker or bottle cap. So it's going to look like this. After you do that, you're going to want to fill this thing with water. This is just regular water so that your substance gets mixed around in there. You could even give it a little mix if you want to make sure with your spoon or whatever you used it to get out with. Then you're going to place the strip in there. The strip looks like this. So you're going to always want to put this squiggly side in the water regardless of which brands you're using, this little dotted area. So you're going to want to stick this in here and you're going to wait for 15 seconds before removing the strip from the water to make sure that it has enough chance for the water to come up here and do its thing. Something that I'll mention while the strip is doing its thing is that you have to test an entire sample if you want to be sure that an entire sample doesn't have anything anywhere in it, although residue is fine for testing purposes or a very small amount of your drug, as you just saw there. Once it's been 15 seconds, you want to take this guy out and just lay it flat on any flat surface. And it's going to show up with either 1 line if it's positive for fentanyl or 2 lines if it's negative. There are some cases where the second line is very faint. That does still count as negative. If you get any other response, that is an inconclusive test. So Dan Steve's instructions do tell you to wait up to 2 minutes for this, but you can see it very quickly on the results. So we have 2 lines because sugar's negative for fentanyl here. And that's it. That's how we perform tests. There's a similar process for xylazine strips as well, and I'll be available during the Q&A or after that if anybody would like to chat more about them.
Great. Thanks, Julia.
Thank you.
So I was gonna say, we'll make
sorry.
sure, just as I'm transitioning, sorry, this platform's a little bit hinky. Give me 1 second. All right, we should be ready to rock and roll.
All right, everyone, this is my email. Just feel free to reach out directly if you would like to talk more about fentanyl or xylazine test strips, the brands of these strips that are available, and that Act 111 that we mentioned that made drug checking materials legal in Pennsylvania did cover other further drug checking materials, reagent drug checking kits and the like, which is something that Dan Safe kind of specializes in. So if we have other questions and thoughts about that, those are also welcome. Thank you.
Okay. Thank you so much, Julia. We really appreciate you walking us through that. Our next presenter is doing things a little old school, so bear with us. But we have Carla Sofronski from the Pennsylvania Harm Reduction Network, who's joined us by phone, and I'll be sharing her slides with you all as she presents. But she's going to build on some of the information that Julia just provided and talk a little bit about some of their work around test strips. So Carla, we're ready to have you take us away.
Hello and good morning, everybody. And I don't know about you, but I love an old school approach. So we can do more than one thing. Julia, thanks so much for your presentation. You did a great job, and I'm happy to come in behind you and talk a little bit about the history of drug checking. And for those of you who don't know me, my name is Carla Sofronski. I'm the Executive Director for Pennsylvania Harm Reduction Network, our statewide advocacy organization that focuses on evidence-based helpful drug policy here in Pennsylvania. If you want to check us out at pahrn.org. And let's just jump right into it. Next slide, please. So the reason we are all here today to talk about naloxone and talk about drug checking strips is because of all of the advocacy that I'm sure many of you on this webinar right now have participated in, and we had a great victory last November, which was House Bill 1393, which was sponsored by Representative Jim Struzzi, who is a representative in Indiana County. This was a bill that unanimously flew through the House and through the Senate. There was a lot of work and education that a lot of advocates had put into this. A lot of time went into this, and thank you all for anybody that's on the call who participated in that. And yay, we got a win, and that's why we're all here today. So a little bit about the bill and what you should know. I'm not going to go too far, but there are three things. Is that number one, all drug checking tools used to test substances, illicit substances, are now legal and do not qualify as paraphernalia. So that's a huge round of applause for the Pennsylvania General Assembly right there. And this covers all third-party possession and distribution. So what does that mean? These were actually two amendments that us as advocates really pushed for in this piece of legislation. That means that third-party use is considered okay, meaning if I were to hand a test strip to Julia, and Julia took that test strip and then handed it to a friend of hers to use, that distribution of the third party, being Julia, is legal and okay in Pennsylvania. The other thing is that the legislation, this bill, is now legal for all drug checking. All drug checking. So what that means is now xylazine test strips are legalized, reagent testing is legalized, and also different forms of drug checking technology that we use now and will continue to use in the future as our supply continues to change. One thing to highlight is that this does not cover other paraphernalia. And this is important to really think about as you are educating others. So paraphernalia, for example, syringes outside of Pittsburgh and Philadelphia are still considered illegal to have. Smoking kits, the same. And hopefully soon enough, we will come together and get the syringe service program legislation passed. But until that passes, this is where we are. Next slide, please. So a little bit about community-based drug checking and the reason why it's important that we bring to these strips. And so test strips, just to clearly define, are drug checking technology that detects the presence of fentanyl in a small sample of the drug. And they allow individuals to make informed decisions about their substance use and potentially reducing the numbers of fentanyl-related deaths and promoting safer drug use. And policymakers have embraced their use of harm reduction strategy to protect the health and safety of individuals who use drugs. It is nice to see our Pennsylvania General Assembly and local government and local single county authorities really embracing drug checking materials. As Julia had mentioned, it is just one tool in the toolbox, and it's considered a Band-Aid, but we know that this is something that's greatly needed here in the state of Pennsylvania. The next slide. So who would be best using drug checking equipment or testing strips? And really thinking about this, right? And thinking about the different populations of folks. If you're a provider or an organization or just a small group of people that are out there on the streets doing distro, or maybe in the woods doing distro, here is something to be thinking about. So who we're giving our strips to, right? So the first one to just go over is our daily users. And let's be real, right? So daily users know what, for the most part, what they're consuming. They know they're consuming fentanyl. That's not a surprise. Xylazine testing is essential in this context. And as Julie had mentioned, xylazine test strips, and I know that they will be made available in the fall through the PCCD portal. I would not say that 100% of daily users do know that they have a xylazine in their supply. If we were to talk to folks in Philadelphia, the surrounding counties in Pittsburgh, 100% they are more educated on their drug supply. As we move towards central Pennsylvania or maybe north, some may not know, so never do distroing with the expectation of thinking everybody knows that a xylazine is in their supply. The other population is the weekend partier, right? So these users may not be aware of the existing drug supply at all. And these are folks who maybe just want to use on a Saturday night, whether it's a stimulant or a different type of opioid, or more of like a party drug, such as MDMA or K. Their sporadic usage equates to a lower tolerance. And this group is less open about using opioids typically. Again, like I had said, it kind of revolves around the party scene, around psychedelics, or people who just want to use stimulants on the weekend or maybe a Tuesday. The other group is people who are experimenting. And this kind of takes us down to our younger population of teenagers and young adults, and they're primarily unaware of our current drug trends. They don't have these graphs and maps to look at like we do to know about the overdose crisis. I'm sure they're aware of the overdose crisis, but again, not really in tune to current drug trends. And last but not least would be the disability community. And this group lacks awareness of current drug trends and harm reduction strategies. Move on to the next slide. And so in thinking about drug checking materials, pairing drug checking with interventions like naloxone and syringe distro can definitely enhance overdose mitigation by encouraging mutually reinforcing risk reduction behaviors. A lot of people like to talk about different ways that drug checking strips may, well, you know what, we're going to go into the next slide. So the last thing I'm going to say before, I don't want to jump ahead of ourselves, and I'm sorry about that. But we know from data, right, through evidence-based practices, because harm reduction is rooted in evidence-based practices, that risk reduction behavior can take place when folks know what's in their drug supply. Additionally, drug checking also creates a pathway for engaging clients and connecting them to services included Hep C, HIV testing care, and substance use treatment. We know that folks who visit places like Prevention Point or are chatting with folks who are doing syringe exchange in the streets or in the woods, that they are 5 times more likely to go to treatment. People who engage with people with lived experience typically creates this pathway. And I'm ready for the next slide. So here's kind of where I was heading with the last slide, is that knowledge is power. We know this. And real-time knowledge empowers individuals to make more informed decisions about their drug use. Drug checking has been shown to lead to positive behavioral changes among people who use drugs, such as reducing consumption, using more slowly, or altering the route of administration, which we know can help reduce risks. Studies have found that individuals who receive test strips from service providers often share them with their peers, so they're doing their own distroing, indicating that peer-to-peer distribution is an effective outreach strategy. So thinking about that as folks are ordering through here, through this portal, through PCCD, when answering questions, are we connecting with people who use drugs who could possibly reach other people who use drugs? 99.9% of the time, I would say yes. Positive results from drug checking tests can also lead to changes in drug using behavior. And for an example, individuals who have had a positive fentanyl test results were 5 times more likely to report changing their behavior compared to those who did not test positive for fentanyl. People who use drugs do want to know what's in their supply. I know when I use drugs, I wanted to know what was in my supply. It's not going to change people who use drugs to not use drugs. Let's be clear about that. However, folks can make more informed decisions. And we can go into the next slide. Stigma. So real quickly, I just wanted to go over some common objections that I myself, some of you on this webinar, I know Julia, have run into. And we just want to very quickly brush on them right here. There's no evidence that HR programs increase drug use. Oftentimes, people have a misunderstanding of what harm reduction prevention programs are. And we always want to continue to educate people what harm reduction programs look like, right? And so the number one thing is that harm reduction is not promoting drug use and is not condoning or enabling drug use. Drug checking encourages drug use. That's another, oftentimes when we were doing some education with our legislators, who didn't understand the purpose of drug checking tools, they felt that it encouraged drug use until we showed them studies and then explained how behavior can be modified. Another misconception is syringe service programs encourages drug use. Oftentimes people feel when they see the word syringe or they see maybe a syringe, oh my God, a syringe, you're encouraging drug use and drug addicts. We know that that's not true. The data says that we've set the data out. We are one of 10 states in Pennsylvania who does not have legalized access across the state of syringe service programs. That's something that needs to change. Another misconception is people who want to use drugs will use drugs anyway, with or without drug checking or any other risk-reducing products. And we know that that's not true, as we've talked to many different populations of people who do check their drugs and folks who have not had access to drug checking strips. For anybody that's really struggling in an organization with this, whether it hits different points within inside you of maybe, for a very long time you thought that this does condone or enable use, I often like to refer to this example is that it's the same way as passing out free condoms. It does not promote sex. Drug checking does not promote drug use, but it does encourage safer behavior. And we're coming to an end. The next slide. Everybody that's on here, I want to thank you for adding life-saving tools to the toolbox. And if you want additional information, please feel free to reach out to us. Here's my email, our website, and our handle for social. And we hope that you join us in the advocacy fight to continue to move forward with evidence-based practices. Thank you so much.
Thanks, Carla. All right, so moving over to naloxone formulations. So one of the changes to the program compared to the naloxone for first responders program that we hit on earlier was the fact that we now have expanded beyond intranasal 4 milligram to also include additional intranasal, including 8 milligram, as well as intramuscular. Worth noting, we can only purchase vials of that, but if that's something you're interested in, certainly reach out and note that in the request form. So So because we're expanding options beyond just intranasal 4 milligram or what might be more commonly referred to as Narcan, we really wanted to provide you all with sort of an expert perspective on what those formulations look like, what they mean, how they work, because we know for a lot of stakeholders that have reached out, they may not be familiar with anything beyond 4 milligram and might just have some questions about maybe some things that they've heard about either stronger formulations or other types of things. So we really have the benefit of having a real expert with us today, Dr. Michael Lynch, who serves as a medical advisor for DDAP and has a lot of other great expertise and work under his belt to kind of walk us through it, talk a little bit about what things are and aren't, and do a little bit of myth busting, so to speak, with the group. So Dr. Lynch, the floor is yours.
Okay. Thank you very much. I appreciate you having me and the opportunity to talk to you about this. So just as a very brief background, and much of this is probably not new information, but I always prefer to level set about what things are and what they are not. Naloxone is a blocker, for lack of a better word, at the mu opioid receptor. And importantly, what that means is it really doesn't do anything else. So in a person who does not have an opioid in their system, it really doesn't do anything. It doesn't have any side effects or adverse effects to somebody who does not have an opioid in their system. If they do, whether it's intentional or therapeutic or unintentional or illicit, it will block the effect. It'll compete for that opioid and it'll block the effect of the opioid. Good things about naloxone is that it's very fast acting. The onset is very rapid. And another, what I consider to be a relatively good thing is it's fairly short acting. And by that, I mean, you know, half-life is about an hour. And so by about 4 or 5 hours, the effect is nearly gone. And the reason I say that I think that's a good thing is because, of course, we want to reverse respiratory depression and save people's lives. But what we don't want is to have prolonged effects and some of the negative effects that can occur in people, particularly those who are physically dependent on opioids. Adverse effects are very rare, less than 1%, and typically related to withdrawal. So again, as a medication, it's very safe, certainly relative to an overdose situation. And that's why our teaching all along has been, when in doubt, better to give naloxone and be wrong and not have needed it than to hold it back. There's all sorts of ways of giving it through the IV, which we can do in the hospital and the paramedics. Bystanders are going to typically be giving it intranasal. They can give it intramuscular if they have that formulation or are comfortable with it. Can be given under the skin and through an endotracheal tube. Though again, that's something we rarely do these days. Next slide, please. Now, we talked a bit about the number of reversals that we've seen in Pennsylvania or that have been reported, and I think that was an important point. It's always hard to know when naloxone goes out the door how often it's used, in what circumstances, how many reversals there are. This was, I think, a helpful report that tried to frame that, looking over, you know, almost 2 decades and more than 150,000 kits that were distributed. And of those, they had, again, reported more than 26,000 overdose reversals. So roughly 1 in every 6 that they distributed, they got reports that it was involved in a reversal. And so I think it's just helpful to have some data, at least, to estimate that, because it's very hard to track once you've given it to someone. Next slide, please. So then, you know, we've talked about the different formulations that are now available and how to use them. You know, as a general rule of thumb with naloxone, the ideal dose, and again, ideal doesn't always match with real world, but the ideal is the lowest dose that's required to restore breathing, not necessarily to wake somebody up. So I think this is one common misconception that leads to some of the concerns about needing higher doses of naloxone, is people expect and hope and anticipate that a person will go from essentially unresponsive and maybe not breathing to fully awake and conversational. That's actually not typically my goal or our goal as a medical community with naloxone administration. typically what we're trying to do is to restore breathing. And if we can restore breathing and make somebody sort of arousable but not fully in withdrawal, that's exactly what we're aiming for. Now in the hospital, it's relatively easy for me because I have people on a monitor, I have an IV, I can give little doses and titrate that dose. You know, in a pre-hospital setting, certainly for a bystander, you don't really have that luxury. Nevertheless, we still would like to aim for that reversal of respiratory depression without necessarily inducing withdrawal. And in any situation where you come across somebody who doesn't appear to be breathing or not breathing well, whether you think it's an overdose or not, whether you're going to give naloxone or not, whether naloxone doesn't seem to be working or not, you want to assist ventilation, ideally with a barrier in either mouth to mouth, or if you have a device to administer breathing or oxygen. Any of those things are good and appropriate, because quite frankly, sometimes when you find people unresponsive, it's not because they've overdosed, something else happened. And so, you know, the best thing that you can do, whether it's an opioid overdose or not, is help them breathe while getting ready to and administering naloxone and then waiting for it to work. And you can see the doses here. The approach is the same, whether you're giving it intramuscular or intranasal, which is to give a dose, whatever kind of dose you have available to you. Ideally assist breathing and wait several minutes. Now, I am fully aware that each one of those minutes can feel like a lifetime, especially if it's somebody you know, somebody you love, or just because you're a human being and it's another human being that you're taking care of. But we ideally would like to wait a few minutes for it to take effect. Relative to other medications, it's pretty fast. Relative to our lives and people not breathing, obviously that can take a bit of time. If it's not working after 3 or 4 minutes or so, then give another dose. Always continuing to help the person breathe or provide oxygen. And ideally, EMS would have already been notified, so hopefully they will be arriving soon to do a more thorough assessment and intervention. So whether you're giving 4 or 8 milligrams, the approach is the same through the intranasal. If you're giving intramuscular, a lot of times it comes as 0.4. Sometimes we see 2 milligram vials. Whatever you have available, just give a dose as a bystander. Reasons that it might not be effective. So maybe you've given a dose, waited a few minutes, and it didn't seem to be working. So you gave another dose and waited a few minutes, didn't seem to be working. And you're thinking, wow, why isn't this working? The most common reasons that we see are, one, it's not an opioid overdose. Either it's an overdose of something else, or it's not an overdose at all. I've seen people with pneumonia and sepsis who are unresponsive being treated with naloxone, and of course that's not working to bring up their oxygen levels. I've seen people with intracranial bleeding treated as an opioid overdose, and of course it won't work. No harm is done by giving naloxone, but that would be one reason it's not working. Another, and this was discussed earlier, xylazine as a perfect example, but not the only. Certainly benzodiazepines and other sedatives are available in our community, in our drug supply, either kind of mixed together or used separately. And if you reverse the opioid effect with naloxone, as I said before, it only does one thing. It reverses opioid effect. So it would not do anything to a sedative effect. With most sedatives, including xylazine and benzodiazepines, they have minimal independent effect on breathing. So in many cases, the naloxone will probably restore some, most, or all breathing, even if they don't fully wake the patient up. And if it doesn't seem like they're breathing well enough, again, continue to assist their ventilation. But that would be a reason that you would give lots of naloxone and not see somebody wake up. And then sadly, the final reason we sometimes see naloxone not working is if somebody's really been down for a long period of time, it may be too late. So that what you're seeing is actually a manifestation of the brain and cardiovascular injury and not opioid effect. So even if you reverse the opioid, the coma and lack of breathing may continue. Next slide, please. This is just briefly to show, this is a study looking at serum concentrations, so concentrations in the blood when we've given naloxone, whether in the muscle or intranasal at different doses. And one thing that is clear and is undeniable is that the higher the dose, the higher the serum level that we can achieve. And at earlier times, we do see higher levels with 8 milligrams versus 4 milligrams versus 2 milligrams versus 0.4 milligrams intramuscular. But I think what's important to recognize is that even now, even these days, most overdoses that I've seen respond well to the 0.4 milligrams intramuscular or the 4 milligrams intranasal if it's given correctly. Next slide, please. So knowing that we can achieve higher levels, with many things, we say, more is better. Why wouldn't we give something that leads to a higher level in the serum? And sometimes that's true. In this case, it's not always better. So data suggesting a need for unusually high doses of naloxone is primarily anecdotal, or it's surveys of people who think they've had an experience where they've had to give higher doses, and reading a lot of case reports where people have given really large amounts and things like that. Usually what happens is one of those situations I outlined is present. There's something else there, it's too late, or they don't wait long enough, or it's not given correctly. Those are common reasons. So there's not really good data to tell us that even though we know fentanyl is more potent, that it requires a much, much higher dose. One part of that is that it has less to do with potency and more to do with binding of the opioid receptor. And naloxone still binds the receptor more favorably than fentanyl. We have seen a drift towards needing higher doses than we used to use. But again, typically with the 4 milligram dose intranasal spray, we occasionally see a need for a repeat dose, but that's not terribly common. In clinical settings in the emergency department, when I have to give repeat doses, usually it's less about needing higher doses really quickly than it is about needing additional doses later on because somebody wakes up, but then they get sleepy again because it's a long-acting drug or it's particularly potent. So as the naloxone is starting to dissipate in their system, the effect can take over again, especially if they don't have a high tolerance. So the repeat doses certainly are needed, but it's pretty uncommon that they're needed immediately, though again, it does happen in probably maybe up to 5% of cases, which is why all of these packages come with 2 doses available. And again, not only are we finding that typical doses do work in nearly all situations, there is potential risk or harm associated with giving much higher doses. One is, when we give more, the risk is that we can cause withdrawal, pain, vomiting, diarrhea. Those typically aren't things that are going to, result in long-lasting detrimental physical effects to somebody, but one, we don't want it, and two, it reduces the likelihood that somebody might be willing to engage in treatment, in talking about what their treatment options are, or even just engaging, period, even if it's about further harm reduction. There's fear and aversion to future naloxone administration. I'm sure many of us have experienced speaking to people who use opioids or dependent on them who have received naloxone, and there's a great fear of receiving it because of those adverse effects, and that could negatively impact future reversals. And we did also do a study where we looked at pre-hospital reversals and found that doses greater than 4.4 milligrams overall in a pre-hospital setting were associated with a higher risk of both aspiration and pulmonary edema, or lung complications, where fluid can build up in the lung and negatively affect somebody's breathing even after they've been reversed. So all this to say is, there's not only one dose that always works the same way for every person, but the need for much higher doses really hasn't been shown, even though our opioids are becoming more potent, and certainly something we'll continue to monitor for any indications that typical doses are not generally effective, even when occasionally repeat dose is required. So next slide. Turn it back over. Happy to answer any questions. So.
Great.
Thank you so much.
We might take you up on that, Dr. Lynch. All right, Alyssa, it's all you.
Awesome. Well, thank you, Dr. Lynch. And we are in the home stretch, so you're only going to have to listen to me talk for a few minutes, and then we'll get to some of your questions. But we did want to just cover the naloxone, so the Narcan that will be going over counter. So the OTC status is expected to begin in the next few weeks. I'm sure some of you have been aware of this, and some of you are aware that the boxes are going to be in retail stores as well as pharmacies like CVS and Rite Aid and things like that. But the packaging will look a little bit different. So we just wanted to touch base on that. So as we roll out this program and we're offering different products and new resources, we did want to just talk a little bit about what the difference is in the boxes as well as the medication itself. So I just want to be clear, nothing about the actual product and medication will change at all within the Narcan brand. So Emergent Biosolutions will continue to provide the same amount of product, so it will still be 4 milligrams, 2 doses within each kit. With that said, the boxes will look a little bit different, so they will be revamped. So the box in the middle, the pink one, that will be what will go into the stores, so that will be what you will see on the shelf. I apologize, I don't know what the price will be quite yet. They have not released the price for consumers, so once that is available, that will be available to you over the counter. What we will be shipping will be the white box on the right side. So the box will be a little bit bigger, and the actual cartridges that the naloxone is coming in will also be a little bit taller. So I think you should definitely take that into consideration when making large orders, that the size of the boxes will be a little bit larger than they typically are. And I know we have received quite a few questions about naloxone vending machines. It kind of depends on which vending machine you're utilizing. Some of them you can adjust them for the height and the different sizes, but you would want to check with the manufacturer of that vending machine. So we just wanted to touch a little bit base on that, and if you have any questions, feel free to put them in the chat. But Sam, if you want to go to the next slide, we're going to open it up with questions. So like we said in the beginning, we cannot hear you, but you can hear us. So in the Q&A feature, please submit your questions if you haven't done so already. It does appear that there are some questions in there. We've been monitoring them as they've come in, and we'll try to answer as many questions we can over the next several minutes. If you have if there are any questions that aren't answered today, we didn't have enough time or we're not able to fully address the questions, we will do our best to make sure that we address them through other means, including an FAQ on our website, which we shared the website in the chat. So with that said, I'm going to go read the questions, and I will ask our presenters to be ready to answer any of these questions. So the first one's going to go to Sam. I know we talked about it a little bit in the beginning, but how can groups become recognized entities? Do you mind just giving a quick overview of that?
Yeah, absolutely. So more information about that process is definitely going to be in the guidelines that's available on our website. So there's a link in the chat that can take you right there to that web page, and you can see under the resources tab, you can find a link to the request form, guidelines, all that good stuff. As I mentioned before, the application to become a recognized entity is actually built right into that request form. So you'll get to a section and it's going to ask you if you are interested in becoming a recognized entity. So if you are and you want to complete that application, you should do so and select yes, and it'll prompt you with those questions. We're also happy to post maybe a full form reference on our website so folks can see what those questions will look like in advance. They are all in SurveyMonkey. You should be able to kind of stop your work and pick it back up as long as you're using the same web browser, but we'll make sure to post that as an additional reference point so you can see what types of things we're asking for. In general, we're looking for kind of what organization you are, your history working in this space, how connected you are to your community, your plans for distribution, things like that, and certainly the types of products that you would or would not be interested in providing. So we'll make sure that that website's up to date, and we can certainly follow up with information on that application process if it would be helpful.
Perfect. Thank you, Sam. And I did see that we did respond to one of these questions, but I did want to just highlight that we will be sending out the slides from this presentation today. I know some people had some audio issues, and so we will be sending those out in the near future. This next question I would say is for Dr. Lynch. So this individual asked, both Narcan and Clexato recommend 2 to 3 minutes between doses. Why is your recommendation 3 to 4 minutes?
Yeah, I mean, it's 2 to 3 minutes is fine. 3 to 4 minutes. The idea is just to wait a few minutes. That is sort of typical emergency department management recommendations and treatment in a pre-hospital setting. It can be a shorter period of time. The point primarily is just to wait a bit of time, because we see people give and then kind of give again within 60 seconds. By sort of making that time frame, it's more about trying to reemphasize the point that there is a need for some, to wait and provide that rescue breathing in order to give it. But 2 to 3 minutes or 3 to 4 minutes as far as recommendations, I think just varies depending on the sources where you see beyond just the drug company labeling, but 2 to 3 minutes is perfectly appropriate.
Perfect. And we did have a couple of questions about people asking about when they should be concerned about, brain injuries and other things. Is the best recommendation, if you are concerned about that, to contact somebody, or what's the ideal course of follow-up for those individuals?
Well, yeah, it certainly varies quite a bit on what degree and what type of brain injury. With anoxic or lack of oxygen brain injury, it can lead to a sort of a global injury that requires physical medicine, rehabilitation kinds of follow-up. It can lead to strokes depending on somebody's like blood vessel status and things like that, with more localized. So it really depends, but can result in sort of psychiatric or behavioral manifestations as well. So it's a complex issue. It certainly needs to be managed through a healthcare provider, and there are even providers who specifically manage in post-cardiac arrest and brain injury rehabilitation for long-term recovery. And as far as short-term, as somebody who is responding, the best thing you can do is administer oxygen and/or breathing as soon as possible to limit potential effects, because it can begin to be brain injury within minutes of somebody stopping breathing.
Perfect. Thank you so much for answering that question. I know it's a little bit depends on each situation, but a few people had asked it, so thank you. And then the next question, I'll answer part of it and then I'll turn it over to Sam. So somebody did ask, how can I get Naloxone for free? And I think that's a great question, right? So we talk about a bunch of different formulations and things like that. In the chat, we did publish the website where you can go to view the different locations. So in the beginning, we did talk about an interactive map that will be available coming shortly. So once that is up, you'll be able to see all the locations in the state that are currently CCEs, and they do provide Naloxone to their communities and first responders, traditional and non-traditional. You can also go to our website and request through our new form and make that request for Naloxone, either variation that you would like to obtain. But Sam, I don't know if you have anything else to add.
Yeah, I mean, all of the products that we're purchasing are going to be provided at no cost to the requesting organization or the individual who's getting it from someone that we shipped it to. So all of this is for free. I should also say, we talked about kind of large and small supplies in terms of quantities, which again are available on the request form homepage. If you're requesting Naloxone directly from us, if it's intranasal, those are going to come in cases of 12 kits or 24 doses each. So that's sort of the smallest amount, so to speak, that we could provide directly to an entity that's requesting Naloxone. And then for our test strips, they come in 100 strips per box for fentanyl test strips and 25 strips per box for xylazine test strips. And that's across both brands that we offer. So if you're looking for less than that, I definitely think that the Mail to Home program that Next Distro runs is a great resource. And I'm not sure Julia might be able to speak a little bit more to that, but going to somebody in your community as well who's a recognized entity could also be a way to get a smaller supply. But those are the quantities that we ship as standard practice through this program, again, at no cost to the requesting entity.
Yeah, we'll send about 1 to 3 Naloxone kits at a time generally for the next mailing program, and are happy to support people who need small amounts.
Perfect. Well, thank you. And a lot of this information will also be on our website. So I believe that's been shared in the chat. So once you go to our website, we will have links to a lot of these different locations and resources. I know some people are asking about training resources. So, we will continue to post training resources on our website. And if you have any individual questions, you can always reach out to us as well at our RA account, which will be on the next slide. We do only have a few more minutes, so I do want to answer just one more question. And then also I do want to make a really quick correction. So it appears that the OTC price for a lot of locations has been published specifically today. So when I wrote my notes, it had not been, so I do apologize. And I did actually talk to Emergent for the OTC price. It will be $44.99. And of course, it will depend on where you're obtaining it, if they are going to mark it up or anything like that. But from the distributor, it is $44.99. So I apologize for that. And then one last question, will quarterly reporting look the same for recognized entities? I'll turn that one to Sam, but it will be a little bit different.
Yep, totally. So we'll have a data reporting form that we publish. So the way that'll work, if you're a recognized entity, we're going to ask you to complete that at least on a quarterly basis. If you're a CCE, you're used to us asking you to complete a spreadsheet. We are moving away from that to probably using an online form instead. It just makes it easier for us to aggregate that on the back end. For folks who are not recognized entities, we are going to ask you to provide a little bit of information on how you used the supply that we gave you before we provide you with another one. So we're not going to force you to provide any information that you're not able to or don't want to. And certainly if you need help, just reach out. But some examples of that are going to look like the number of test strips that you distributed. So how many of what we gave you did you give away? If you're giving out naloxone, same type of information. If you're able to get reversal utilization, awesome. If you're not, no big deal. But all of that information on the metrics that we'll be asking folks to kind of track on and report are available on the program guidelines, which again are posted to that web page that we shared earlier. If you have any questions about any of that, you can see that the resource account that Alyssa referenced is right here. I will read it aloud in case folks want to access it that way. It is RA-CDPA-overdose without the E, so OVERDOS PREV at pa.gov. Just rolls right off the tongue there. But it's all over the webpage, all over our guidelines. And, you know, don't hesitate to reach out. Alyssa and I and some other team members monitor that account pretty closely. Back to you, Alyssa.
Perfect. Well, it looks like we have reached all of our questions that we're able to answer at this time. And so, like I said, we will be posting answers to questions. And we will be sharing additional resources on our website. So, you know, if you have any questions, feel free to reach out to us through that, through the RA account that Sam shared, or, you know, check out our website. But I'll turn it over to Sam. But I do want to just thank everybody today for presenting and attending. So back to you, Sam, if you have any final remarks.
Yeah, no, I'll echo the thanks. A big round of virtual applause to all of our presenters for sharing their time and their expertise, and certainly the same round of applause to all of our folks who attended. We know that your time is precious, and so we appreciate you spending a little bit of it with us today. If you have any questions, reach out. Please bear with us. This is a new program. We're doing things as quickly as we can, and we want to get supplies out as soon as we're humanly able to, but we are only humans. So we appreciate everyone's patience with us as we navigate some of the purchasing logistics for you. If you need anything, questions, don't hesitate to reach out. Thanks to you all. Hope you have a wonderful afternoon and a great start to the fall. And we look forward to hopefully sending you guys lots of good supplies to help your communities. We'll talk soon.